So good morning, everyone. Welcome, bienvenidos. For those of you who want to continue in English, please stay put. Las personas que desean escuchar la versión en español, por favor, elegir el idioma oprimiendo el botón en forma de círculo donde dice español en la parte inferior de la pantalla. Gracias. Good morning to all of our live attendees today. We are so thrilled you're here to engage in this exciting webinar, Sex Therapy and Integrated Behavioral Health. I'm Dr. Tiffany O'Shaughnessy, and I'm one of the hosts of our webinar today. I use the pronoun she, her, and I'm a white cisgender woman in my early 40s with an undercut buzzed hair on my left side and chin-length pink hair on my right side. I'm wearing a black top, and my background is an office with a fiddle leaf fig and a beige couch and a blue floral painting. I'm a professor and the MFT program coordinator in the Department of Counseling here at San Francisco State, and I'm one of the co-investigators for this project. I'm working alongside the project's primary investigator, Dr. Julie Cronister, who's our department chair, and my co-investigator, Dr. Molly Streer, who's the coordinator of our school counseling program. I would also like to thank our graduate assistants, Sarah Guerrero and Jenny Zing, who are working hard to stay on top of the technical issues, chat boxes, etc. today. I'd like to acknowledge that SF State's campuses in San Francisco sit on the ancestral homeland of the Ramaytush Ohlone. We further acknowledge that we work on the ancestral lands and waters of many other Indigenous peoples and nations in our fieldwork in the Bay Area and around the world. We're committed to ensuring this webinar is accessible to our audiences. Closed captioning is available in the closed captioning option at the bottom of your Zoom screen. If at any time your access needs are not met or become not met during the webinar, please send a chat directly to a host or co-host. Access is always a work in progress, so we appreciate your comments, feedback, and support. This is our first webinar of the year, sponsored by our Equity and Justice-focused Integrated Behavioral Health Counselor Training Project, which is funded by the Department of Health and Human Services, Health Resources and Services Administration as part of an award totaling $1.9 million. A couple of additional things before we begin. If you're one of our HRSA stipend recipients or are interested in receiving continuing education credit for your attendance today, please pay close attention to the announcements provided in the chat for sign-in and evaluation links. Our thanks to our partner, Counseling and Psychological Services at UC Berkeley, who are approved by the American Psychological Association to sponsor continuing education credit. As a reminder, this is a live recorded Zoom webinar. Therefore, the audience is not visible and the audience can't turn on their video or audio. The chat function is available for comments, sharing of resources, supportive emojis, etc. To ask the presenter a specific question, please post your question in the Q&A function. Q&A will occur during the last 10 to 15 minutes of the webinar, so please post your questions in that Q&A as they emerge, and then the presenter will answer questions at the end of the webinar. If we can't get to all of them, you can contact the presenter directly. The information will be posted in the chat at the end of our session. And so it is with great pleasure that I introduce today's presenter, licensed professional clinical counselor, Gil Perez. Gil Perez is an AASECT certified sex therapist and an award-winning tenured faculty personal counselor at the College of San Mateo. He provides mental health services to students, consultation to colleagues, and teaches counseling courses. He oversees the Mental Health Peer Educator Program and is the chapter advisor for Active Minds. He served on the California Community College's LGBTQ+ Advisory Committee, composed of influential community college leaders across the state aimed at establishing equitable support to achieve LGBTQ+ student success. By advocating for the expansion of LGBTQ+ resources, Gil proudly established the Safe Zone Alliance and Trans Community at College of San Mateo. Amazing. He is a graduate of our master's program at SF State and often professor here, a lecturer or faculty, and currently a PhD student in human sexuality at California Institute of Integral Studies. He also has a private practice where he specializes in sex therapy. I've been so fortunate to know Gil for several years, and I'm so excited to continue learning from him today. So thank you again for joining us, and Gil, please take us away.
Yeah, thank you so much, Tiffany, for the warm welcome and introduction. So this presentation and webinar is titled Sex Therapy and Integrated Behavioral Health. And like Tiffany mentioned, I'll be the presenter for the webinar. And as we get started, it says my screen, is my screen showing, Tiffany?
Your screen is showing. Oh, there it goes. It was kind of
okay.
stuck on slideshow, but now it's in. Now we're on the Let's Welcome Compassion slide.
Yeah, so before we get started, I just want to welcome everyone and also just ground us in some compassion as we move through the material today. We're all here to learn, grow, and change. And just know that, yeah, we're trying our best. I want you all to acknowledge any reactions you might have to the material that I present today. And just be curious about anything that is coming up for you. One thing I'm going to be emphasizing throughout this presentation today is a form of self-reflection as we move through. And then also to know that I am sharing one perspective, also, I mean, many other perspectives, but again, what I share isn't the only perspective on sex therapy and integrated behavioral health. Okay, so this webinar is designed to teach behavioral health providers to integrate discussions of sexual functioning and flourishing into brief integrated behavioral health settings. The presentation will introduce the importance of attending to sexual well-being and behavioral health treatment and provide concrete strategies for providers to implement in their work with their clients. So these are the learning objectives for today. So we will describe the connection between sexual well-being and mental health. We will outline 2 approaches to integrating sex therapy into primary care and behavioral health settings. And then also learn to apply 2 interventions to support sexual well-being in integrative behavioral health settings. This is just a little bit about me. I was born, raised, and currently reside on unceded ancestral homeland of the Ramaytush, Ohlone, and Muwekma, who are the original inhabitants of the San Francisco Peninsula. I'm 33 years of age, cisgender, male, queer, able-bodied, Filipino, which all have shaped and contextualized also my understanding and experiences of sexual well-being and sexual functioning that we'll be exploring today. I am a licensed professional clinical counselor, ASEX certified sex therapist in private practice, and very proud graduate of our SF State Masters of Counseling program. And I currently teach as a lecture faculty in the department as well. And then I'm a full-time tenured personal counselor at College of San Mateo. Okay, as I mentioned, I am a certified sex therapist, so I have gained additional training to provide in-depth psychotherapy to treat clients with sexual issues and concerns. And ASECT is the organization where I became certified as a sex therapist, and our organization believes that every individual has the inherent right to enjoy a life that prioritizes sexual health and freedom. This involves ethical, freely chosen, and individually governed expressions of one's sexuality that are free from undue risk of physical or psychological harm. And this really aligns with my approach and practice to working with clients and also guides my approaches and interventions when serving my clients, especially related to any sexual concerns that come into the sessions. Okay, so I want to start by defining sexual well-being. And there isn't one unified definition. In looking through the literature and online, there's actually a vast and wide variety of way of how sexual well-being is defined. And in considering what would be the most inclusive understanding of sexual well-being, it can also sound very broad too. So for the purposes of this webinar, I am defining sexual being as an individual's subjective assessment of a wide range of physical, cognitive, emotional, and social aspects of relations with oneself and with others. And a couple components, again, it's multidimensional, but a couple components that affect sexual being that I'll explore in this presentation. is one, the experience of sexual function. So in relation to desire, arousal, being able to experience sexual pleasure and satisfaction when desired. And to really note that sexual function is affected by multiple factors, psychologically, socioculturally, and biologically. Um, and then in relation to that, forms of sexual distress and any negative emotions that are associated with one's sexual experience, as particularly related to sexual functioning. Okay, so in terms of addressing sexual well-being, um, if you look online, there's a lot of different data that looks into sexual issues over the course of the lifetime. So um, even the data I have here, it's pretty wide. It says 10 to 52% of men and 35 to 63% of women experience a sexual issue over the course of a lifetime. But really what I want to emphasize is that as a psychotherapist or primary care, it is very likely that you will address sexual well-being at some point in the therapeutic process. And we really do want to find ways to also invite the conversations related to sexual well-being. But to note that for a lot of us, we may not receive formal training in treating sexual issues that may support our both our humility and competence related to working with these issues. And again, in our society, sex is a very taboo topic. So people might be more reluctant to seek out help from more formal sources. Again, I'm thinking primary care, I'm thinking psychotherapy, because sex is a very private, taught to be a very private issue in our society. And so there can be emotional discomfort, there could be lack of knowledge. And so folks might actually end up seeking out more informal or anonymous sources to support their sexual concerns, or might not seek out any support at all. Okay, so these are just some examples of sexual concerns or presenting issues that can more directly show up in the therapeutic space. We're not having enough sex. I'm a sex addict. I climax too fast. I take too long. I can't get or keep erections. I feel guilty or ashamed a lot. I don't orgasm during sex. I think my spouse is cheating on me or already has, or my partners. Too much porn. My partner watches too much porn. Wanting more intimacy, not feeling like they're connecting with folks. Sex is painful. Or just needing someone to talk to, right? Which can also turn into conversations around sexual concerns or presenting issues. And as we talk about sexual issues and concerns today, sexual functioning, sexual well-being, it's really important that we pay close attention to intersecting identities, as each client will have a unique perspective and experience of both their sexual concerns and sex overall. And this includes all aspects of intersectional and cultural group identities. And that in our dominant society, there are limitations to what is a normal way for us to exist and what is viewed as normative. And that this normal way of being, which we may be expected to strive towards, whether or not we're able to actually achieve it on an individual or relational level, is also defined by white supremacy culture, patriarchy, capitalism, and these same systems define what is function and dysfunction in related to sex and sexuality. Okay, so since we're talking about sex, I want to move into a poll. And we have a lot of folks in the webinar today. So I want you to go to the Mentimeter poll. There's a QR code And we're also putting the link in the chat box. And the code is also on the screen. And it's open-ended. I just want you to answer both of these questions. The first one is, what is sex? And the second one is, what is the reason people have sex? So I just want you to think about, when you think about, yeah, sex and reasons people have it, I'm very curious to hear what comes up for folks. And this is anonymous. I'm going to actually pull up the Mentimeter poll on a separate page so I can see folks' responses to it. Okay. Ooh, and they're coming in really quickly, which is great. Let's see. Here we go. I'm just gonna start going through these responses. I'm not gonna be able to go through all of them. But this first question I asked, what is sex? And I'm just seeing words that are standing out. I'm seeing a lot related to intimacy, connection, pleasure, exploration, stimulation. I'm seeing a connection between people, between consenting adults. I'm seeing reproduction, penetration, intimate act involving genitalia. It can also be emotional. So we're breaking down intimacy, physical or emotional, erotic play. I'm seeing procreative act, intercourse, and also scrolling a little slow so folks can also see other responses. Of course, I'm sharing what I'm seeing is standing out. It can also be solo. It could be for fun. It's play with oneself for others. Um, Traumatic connection, exploration of mind, body, and pleasure. Yeah, keep adding to the list. Wow, 44 responses. But yeah, I'm seeing a really expansive understanding of sex and what sex could be and what sex is for others as both an idea, concept, or act. So I'm going to move to the next question. What is a reason people have sex? It should be the same code for folks to also get to it too. The next question. Okay, awesome. Responses are coming in because it feels good. There might be primal urges, might feel very innate, this desire to have sex. Again, I'm seeing a lot of connecting with self or others. I'm seeing procreation come up. There are needs we have related to intimacy, for love. Yeah, there's so many answers. Not all of them are healthy. Someone said to orgasm, to feel pleasure, to give pleasure, release, joy, obligation, boredom, curiosity. You might feel pressured to connect, to disconnect, to feel something. Yeah, and I'm thinking back to me just talking more about like sexual functioning and just mentioning there's so many different factors that go into yeah, functioning of sex, but also like the reasons that motivate people to have sex in whatever way we're defining sex as. For many to feel power, to get back at someone who's cheated, strengthen connections with a partner. And I just have this up because I'm also sitting with these different responses. Financial gain. I mean, it's so clear just in these responses just how vast and expansive and just the multitude of reasons that people engage in sex. So thank you. Also everyone for and also everyone has this linked to and it'll be open I think for the rest of the week. So you can continue to take a look at folks' responses to different reasons that people engage in sex. Okay, so I'm going to go back to the slideshow now. Thank you everyone for participating in the poll. So let's continue to talk about sex. So what is sex? And you all really helped me already sort of support this more, again, more expansive and inclusive understanding of how I'm going to be defining it. And what makes an act, a desire, or a relationship sexual is a matter of social definition. These meanings are contextual, it's variable. What is sexual to one person in one context may not be sexual to someone else or somewhere else. There is a heteronormative idea that privileges heterosexuality, and it's sustained through this common sense definition of intercourse-based sex as a sex act. I know for me too, that's also that's one of my initial, what comes up for me when I think about the sex act. And this also shows up in a variety of sexual and relationship orientations that reassert heteronormativity. But again, there's also various ways in which we also challenge them as well. And then why do people have sex? So they're not only sex acts, but also the meanings that they carry, the desires that motivate them, and the social interactions through which they're accomplished. And so sex in itself is neither good nor bad, neither uniquely pleasurable nor uniquely dangerous. It's neither intrinsically oppressive nor liberating. It becomes so through the particular social conditions under which our sexual lives are lived. And at the same time, there are lots of contradictions to sex. So for example, it's taught to be natural, but becomes something that you work at or get fixed, especially from more of an essentialist view about sex in our society. Okay. I do want to mention, I'm going to be talking about a variety of, concepts and ideas. And again, these are just these are different perspectives. They're not the only perspective, but I'm hoping to introduce new perspectives that can expand our understanding. And some of these I won't have so much time to go in depth because, the time we have together. But I do encourage folks to really further explore any of the information, concepts, theories, interventions, and approaches that I share today. If there's anything that really speaks to you that you want to continue to go deeper into. Gail Rubin, an anthropologist, created the Charmed Circle. You can see 1984. And so inside the circle, these are the types of sex that is privileged in our society, things that are seen as natural, good, normal, and things outside of the circle, what is considered bad, unnatural, again, very binary, a lot of binaries around what is good or bad in relation to sex, sexuality. So inside you can see, procreative sex, sex that is free, coupled, you're in a relationship, that is monogamous, married, vanilla, bodies only, no pornography. And again, I mentioned earlier, it's a private thing. It's something you do at home. Same generation. And outside the circle, you see things around like pornography, cross-generational, casual, having sex alone or in groups, for money, non-procreative reasons. And again, I think since then, there also has been more of an expansive understanding of sex, especially related to like pleasure. But I want you to consider even today in 2024, how much this concept still pertains to sex, especially from a heteronormative view. And this could be something that you really look into, what else goes into the circle and what's outside of the circle as well. And also could be an intervention also with clients when we're addressing sexual functioning and sexual well-being. Okay, so this is more of a traditional understanding of the sexual response model in relation to sexual function. And so it is very linear. You can see the arrows going down. This 4-phase cycle was created by Masters and Johnson. And so you can see there's desire as number 1, which turns into arousal, orgasm, and resolution. And so again, this can also sort of support more of this heteronormative medical model view of how we understand our sexual response, and thinking about just ways in which, I mean, look at the list we created in terms of just sex, what it is, and the reasons that people have sex that don't always fit into this like linear model about what sex is supposed to be, which makes it look like it's very intercourse based. You just get desire, arousal, you have an orgasm, and then there's this resolution, and then it happens all over again. But since then, there have been more expansive, like I mentioned, understandings of the sexual response cycle. So I'm gonna play this video, and it's an interview with Emily Nagoski, who authored Come As You Are, if some of you are familiar with it. And she's talking about debunking sexual myths. So I want to just share this video, and it's about 5 minutes long. So we're going to watch this together.
Hey, sex certainly sells, but what if everything we've been taught about it was actually wrong? Well, our next guest is author of the New York Times bestseller, Come As You Are, and she's ready to debunk some common sex myths for us now. Emily, welcome to Studio 10.
Yeah. Hello.
So, Emily, why do people get so shy when they talk about sex?
I think it has to do with fear of judgment. We feel really uncomfortable and unsure about certain parts of our sexual selves. Are they okay? If we disclose to our partner, are they going to be accepting of it? And the risk that you could say something and have your partner go, ugh, stops us all in our tracks.
Emily, your book, I had a bit of a look at it. It's terrific, because I think we all want to know more about sex, how we can have better sex. But often I think that big question is, are we normal? Are we having enough? People always seem to be having more sex than you actually, well, perhaps I actually am.
Right.
So what is normal? How much sex should we be having each week or month?
The amount of sex that feels right for you and your relationship. There's nothing, other people's sex lives are their sex lives, and they try to have the healthiest sex life they can, but that has no overlap or impact on what amount of sex is right for you.
And what are the myths around women and sex?
Oh, there's so many. One of them is that you can tell by what's happening between her legs how she feels in between her ears. It turns out the overlap between genital response for women and how turned on she feels is only about 10%, which is statistically non-significant. So if you want to find out whether or not a woman is enjoying herself, you have to listen to her words, as we teach our 4-year-olds, and not pay attention so much to her genitals.
And Emily, I fear I am one of those people you talked about earlier where I think, well, look, I'm a Catholic. I think that sex should be done at night with the lights out and never spoken of again. Isn't that okay? Isn't it okay just to have things sort of, you know, happen and not have to sort of analyse and pull apart and drag it out? There's nothing unsexier than talking about sex, is there?
Sometimes, under the right circumstances, there's nothing sexier than talking about sex. But the main thing is that people all vary from each other. For some people, sex at night with the lights off and that's it is exactly what works for them. For other people, they really want to try other things. So it's not about which is the right kind of sex to have. It's about which is the right kind of sex for each individual person.
So for each individual person, how can we have better sex? How can we have a better sex life? Are there some sort of rules or things that you would recommend for people?
There are some things that I've found really consistently as I've learned more and more about the research in the last 20 years. What I've found is good advice is consistently, it's not about orgasm, it's about pleasure. Orgasm is one way that you can experience pleasure, but there are lots of other ways. 2, pay attention to your partner. In terms of sexually relevant stimuli, there is nothing more relevant than your partner's pleasure and sharing that with them in the moment. And the 3rd is to enjoy the sex you are having, even if it's not the sex you were taught that you're supposed to be having, or it's not the sex that you wish you were having. If you can let go of the shoulds and expectations and just notice pleasure happening in your body, that's when you really open the door to expansive pleasure.
Now, Emily, here in Australia, we've had a lot in the media recently about violence, about sexually aggravated violence against women in particular. You've got quite an interesting take on consent, don't you?
I do. Learning about the neuroscience underlying the sexual response mechanism changed how I think about and teach about consent. The usual line is say yes to what you want and say no to what you don't want. But because the number one reason why men perpetrate violence against women is sexual entitlement, basically the assumption that the other person's yes or no is not meaningful to them, they have a right to that person's body, combined with the gender socialization for women that it's their responsibility, their value as a human being is tied to their ability to meet other people's needs and make other people happy, creates an environment where talking about what you want doesn't get us anywhere. If we switch instead to a model of say yes to what you like, that changes everything because pleasure is context dependent. If I tickle you and you're in a flirty, fun state of mind, you might like that. If I tickle you and you're annoyed with me, that will not feel so good. So if we talk about consent in terms of what feels good, that means consenting to a context that allows your brain to interpret sensations as pleasurable, and you can't go wrong when that's your standard.
Say yes to what you like. That sounds like a good approach.
Good advice.
Yes.
Emily Nagoski, thank you very much for joining us.
Yes, so there's a lot happening in that video. And one thing I do appreciate that Emily did is she held space for both. And again, there's ideas of what sex is supposed to look like. And I appreciate her validating that for some people, a certain type of sex or what that looks like is what some people want. But again, it's not the sex that everyone wants to have or sex that they do like. And just in expanding from the more traditional sexual response model, again, it doesn't really talk about context and the things that do create desire and arousal. So I really like that she focused on also context. And whether a sensation is perceived as pleasurable or uncomfortable, and how it really depends on how we perceive the context in which we're in, and how we really need to create the conditions for having the consenting to the kind of sex that we do like. But there's a dual control system model that talks about accelerators. And so this is more of like our sexual excitatory system. And this is more focused on like, or things that arouse us. So things like feeling wanted, connected, porn, being touched the way we want to, novelty, surprise. Um, I mean, consent, but the consent needs to be unpacked in a lot of different ways. And previous positive sexual experiences. And again, how to create like more of the conditions that hit the gas on those accelerators more. And then there's the breaks, which are more sexual inhibitory responses. So things like stress, body image, shame, anxiety, any previous negative sexual experiences, lack of consent, um, et cetera, et cetera. More of that and how that can also affect arousal or even desire related to sexual response. So just another way to like understand it, but this one is more, I like the part about context and how there's also different levels of sensitivity, depending if folks have more accelerators or more brakes in relation to, sexual response and sexual function. Okay, so I want to talk a little bit about gender norms and sexual expression. I've been sort of focused on more around this heteronormative understanding of sex and how these sexual scripts really depict people socialized as men as sexual initiators and people socialized as women as sexual gatekeepers. And so, again, these scripts that are more heteronormative in our society really dictate that men initiate sexual activity and that women respond to men's advances. These create double standards, which can permit more sexual freedom for men while restricting women's sexual expression, which can also influence consent communication and also how much agency someone really has in a relationship to consent. And when we consent to things, which is meant to be more of like an active agreement to something, it does not always mean that someone's consenting to something that they want to do or something that they are going to enjoy or experience as pleasurable. So I appreciate also Emily adding that notion around consent. And so this more traditional heteronormative view of successful sexual functioning, again, as penetrative sex that leads to orgasm, can really regulate and set limits on the sexual expression of individuals, and also define gender roles and relations. And so just one example also as I was looking through the literature and things that I do show up more also even in my clinical practice can also be attempts to hurt. The literature focuses a lot on caretaking of egos for men's feelings, but just like the feelings of our partner and not wanting to hurt their feelings and what, the other partner should do with respect to having sex with people who put in the work. And so these scripts give the message. Again, there's this very linear model, and it ends up becoming this sort of about performance related to intercourse-based sex and orgasm. And then the other partner or both partners making sure that they are protecting their partner's ego. So again, it could be taking away from more pleasure-centered sex if sex is centered around intercourse, orgasm, but then tied to what sex is supposed to be. And how that also can affect sexual function, especially if they feel like it's not functioning the way it's supposed to get through that more linear process. It can lead to sexual dysfunction. So again, just giving you a way to just look into things that might seem normative for folks and how they understand successful sexual functioning. as something worth exploring with clients and patients. And earlier I mentioned that queer relations may or may not reassert or challenge heteronormative gender roles. So, the myth that, masculine sex partners have to be the penetrative sex partners, or that female sex partners, have to be the receptive partners. Because penetration and masculinity are conflated with dominance and control. Femininity and being penetrated are associated with being passive and submissive. And again, how much people conform to norms can affect their understanding of what it means to be successful in relation to sexual functioning, and whether or not that regulates or sets limits on someone's sexual expression. Okay, so I want to also address desire. On that sexual response model, it's number one. And from a more medical model view, there might be an understanding of desire as this innate drive for sex. And again, focusing more on gendered socializations, it's often situated as low because of its relative status to a partner's level of desire. And this is not a gender neutral process. When a woman experiences lower desire than a man, than their male partner, her desire is often labeled low. In the case of a man reporting lower desire than a woman partner, the woman's desire is labeled too high. And they might receive backlash or, be called negative words if their desire is too high or they have too many sexual partners. And again, it's not placed on the man's desire being labeled too low. And so this really highlights more of the gendered subjectivity that's inherent to how we conceptualize low desire, where low desire is most often seen as residing not just in the bodies, but again, in women's bodies relative to men's desires. But again, if we're also just focusing on desire being innate, anyone who feels like their desire isn't up to what it's supposed to be is going to feel like there's something wrong with their level of desire. So again, low desire is typically seen as a problem residing in people's bodies, in part because sexual desire is seen as something that's supposed to be natural and universal. And so if it's not working the way it's supposed to be, that's why there's ways in which there's, again, from that traditional sexual response model, ways to sort of fix low desire. But we really want to question, is low desire really the problem? Because desire can ebb, it can flow. There's also a lot of things that decrease desire. Pressures, expectations, a sense of obligation or duty, anxiety, depression, stress, and also asexual individuals have really helped society understand that little to no sexual desire for other individuals is also a part of human diversity. So we really need to explore low desire from just these different factors that can come into place. I work at College of San Mateo, and in my introduction, Dr. O'Shaughnessy mentioned I do a lot of LGBTQ programming, and there's a lot of ace and intersex invisibility, just from the programming that I think needs to be more inclusive. So I started a book club, and the book that we're reading this semester is Refusing Compulsory Sexuality, a Black asexual lens on our sex-obsessed culture. And it really looks at the intersections of Blackness and asexuality, especially where Blackness is related to hypersexuality, which almost illegitimizes Black asexuality because of, just this limited understanding of sexuality. And so there's this quote that I really like from the book, An asexual framework grounded in Blackness engages multiple realities simultaneously. It posits that a world of limited thinking must end in order for the full breadth of the universe of all possibilities to fully thrive, with fewer resistances for us impossibles, mythicals, enigmas, and the more than, less than, and other than humans. And it's been a great way for us to really look at white supremacy culture, cis heteropatriarchy, and again, just expectations of society in terms of just how we're supposed to be, but also because of the discrimination that happens towards more marginalized communities, and things that, again, that affect consent, that also create a lot of violence towards people, sexual violence. So I just wanted to share one example of something I'm doing in my area to help provide more education and space to explore multitudes of different realities and experiences of folks through an intersectional lens. And so also as people age, they experience changes in their sexual functioning, and this is due to biological, physiological, hormonal mechanisms that influence people differently. I also want us to consider health issues, acquired disabilities, side effects of various treatments. There's this article, 2021, that looked at the perceptions of older men and women ages 60 plus regarding their sexual functioning. And again, it's subjective. Older age, for the purpose of the study, they defined older as 60 and older. And all of the interviewees had acknowledged experiencing some change in sexual functioning with age. And with very few exceptions, a lot of them portrayed these changes as negative. And some, particularly the woman-identified interviewees, experienced the changes in their partners rather than in themselves. And so the most common sexual change identified by by all interviewees was male erectile dysfunction, followed by lack of desire and premature ejaculation. So this also partially demonstrates the importance that older adults in this study placed on sexual intercourse, and especially on men's ability to engage in penetrative sex. And the men identified interviewees appeared to be more likely to identify sexual challenges in themselves than in their partners. And so thinking about, when we're addressing sexual functioning, is there a sexual concern, and who is it a concern for? Is it for themselves, or is it something that they see as an issue of their partner or partners? And so there was a small portion, though, of interviewers that did report an improvement of their sexual functioning over time. So I did want to highlight also just these more qualitative anecdotes of what helped improve sexual functioning for them. And so for some of the men, this was done through more of a use of a broader definition of sexual functioning, which incorporated intimacy and attention to one's partner. And for women, becoming more familiar with their own likes and dislikes over time. And again, I'm just highlighting different ways of looking at sexual functioning, right? So instead of looking at things as a decline or an absent, how can we look at things just differently, especially if we're looking at things that just occur through aging, and whereas the majority of equate sex with penetrative sex, some older adults considered other forms of intimacy, such as cuddling, kissing, holding hands, as meaningful forms of sexual expression. I want to briefly touch up on HIV and sexual functioning. And this is more so focusing as an example of sexual distress that someone might be experiencing, but also how more of a multidisciplinary approach and integrated behavioral health can support with addressing sexual concerns. So HIV itself may not impact sexual functioning, but then again, because of stigma, psychological, and the impact of a diagnosis of HIV can have an impact on sexual functioning. So fears of rejection, fear of transmitting HIV to sexual partners, and how that can affect individuals. And so, again, where there might be more psychotherapy support around exploring these fears, disclosure. There's a lot that goes into disclosure of a diagnosis of HIV. And then also ways in which they can protect themselves, right? Whether it's through achieving viral suppression, or their partners, if they are HIV negative, using, again, these are just possibilities against transmission of HIV. There's things like PrEP, condoms, but there's a multitude of factors that need to be addressed that, again, in conjunction with therapy, but also primary care can really support with addressing sexual functioning. Okay, so I'm going to move through this. I know I'm looking at the time and I do want to make some time for questions. But I mentioned just wanting to make sure that folks have time to really self-reflect. And part of our work is really working towards developing a positive provider belief that that sexual concerns are important to discuss clinically. And we want to work towards decreasing any emotional discomfort. So part of it is really looking at our own assumptions and normative expectations of sex. Do we assume that a body part needs to be used in a certain way? How comfortable are we? How does that affect the therapeutic process? And how do we invite the conversations? And what questions do we have about sex therapy? So again, these reflection questions are in the slides for you to continue to sort of, reflect on. And that for us, we also want to really deconstruct any assumptions about sex and sexual functioning. We want to decenter any dominant ideas by asking questions about the assumptions embedded in how sex and sexual functioning is supposed to be. And even if we do sort of like remove the centrality of sex, there's room for both and. I just want it to be clear that, again, there's a normative way of how sex is supposed to happen and work. But again, there's room for all. I want to make room for all sexual expressions for our clients to support with possibilities. And so I just want to go through a list of just sort of like interventions, counseling, and ways in which we can enhance patient-provider communication. So asking about sexual history and concerns during intake and assessment, finding ways to normalize the topic with our clients, to model sexual communication, and letting them know that they can talk about it. Sometimes clients might come in and not know if they can talk about sex. And again, because of the private nature for some folks, they may or may not bring it up. But to meet them where they're at, especially if there's any discomfort around talking about sex, hold space for that discomfort. It might not necessarily be talking about the sexual concerns, but if they are experiencing discomfort with the topic, just to be able to talk about it. And then incorporating more of a biopsychosocial framework to explore sexual concerns. And really creating a culture of inquiry. Have curiosity around what feels natural, innate, what feels like it's the right way, what feels like a universal truth. So you can explore any socially constructed meanings and sexual scripts that shape perception and expectation of sexual functioning and performance of sex. And then to also explore the distress, if there's any fears, anxieties, or worries, rather than only a medical issue to be remedied. Again, we want to make room for both and, that if they want to address any medical issues, but again, through our work, we can really also explore the distress. And that doesn't have to, and that means moving away from a strict perception of sex. And then, supporting clients to adapt to change, think about acquired disabilities, health issues, aging, and how we can explore different forms of intimacy, encouraging the use of sexual communication with their partners and how to have those conversations, resources. And then again, if we are thinking more of a multidisciplinary approach, having discussions. Make sure you're providing a rationale for why there's a referral for a specialist visit. One thing is that if clients do bring up the topic of sex, we don't want them to feel like this isn't something that we want to make space for. We want to know, we always want them to know why we're providing that referral. Because sometimes combining therapies, I'm thinking just one example, sexual pain, where it might be really effective, both medically, providing physical therapy and psychotherapy. And then also contextual factors. So example, partner in the room, finding ways to address that. Again, is the sexual issue a concern for the client, or is it for their partner or partners? So I moved pretty quickly through this, again, because I'm just looking at the time. The rest of the presentation is just looking at assessing for medical contributors. Again, if this is something that needs referrals. So take a look at the rest of the slides. I talked about using inclusive language. This is both for primary care and also psychotherapist. And then the last thing I added to is there's other forms of psychotherapy to explore. Sensate focus is one, and really being able to incorporate touch exercises to help understand and address the relationship between body and mind as a way of resolving any sexual dysfunctions. So I just want to provide resources. Again, I'm not able to go into depth, but things that I think can really support the work based on just any different approaches or orientations that you might have to treating sexual concerns. Okay, I only left a few minutes for questions, but I'm just going to leave it with this little starfish reflection so that as I answer any questions that I can, you'll think about what you can keep doing, what you want to do more of, what you want to start doing, what you want to stop doing, or what you want to do less of.
Thank you so much, Gil. I know this could be an entire graduate program. As you're in, it's like there's a certification in sex therapy, right? But one thing that you just said recently that I think is so important was that piece of when a client, wherever we're at, whatever integrated behavioral health, if we're a social worker, a psychologist, whatever, and a client, if they bring up sex, like sometimes I've noticed folks like shut down or like, oh, I'll get you to a sex therapist. And that like shuts down the conversation. And I love that you said, like, be clear about why. Yeah, definitely. Sometimes we want to partner with a sex therapist, or there's a specialist who needs that, or there's a biological piece of it. But we also, all of us, need to be able to have really frank conversations about sex wherever it comes up with our clients. So thank you for highlighting that. Super appreciate it.
Yeah,
that was awesome.
We don't want them to feel like they're getting pushed. That conversation is getting pushed out. We're inviting it. And if there could be more of a multidisciplinary approach, we want to make it clear why. Yeah.
And I think we have one question that we've got 1 minute, so we're not going to be able to answer this. This should be a whole other special webinar, but someone said, I'm not sure if this was already discussed, but can we cover considerations for providing care around sex to transgender individuals, particularly since those folks experience disproportionate rates of sexual violence and harm when they're seeking medical care? So I don't know if you have 1 minute of something you want to say about trans and non-binary or gender expansive folks.
Yeah, it's very touched up very lightly here in using inclusive language. This was a report from the Association of American Medical Colleges to improve the clinical experiences and care of both gender and sexually minoritized patients. So again, it's more of an expansive, inclusive way of focusing questions around things to talk about sex. So, of course, directly asking, are you sexually active? But questions around like, when you are sexually active, what parts of your body do you use? And not assuming that we know how parts of bodies are going to be used when engaging in sex. And that really also, I'm just going to move back one. I know it's
no worries.
When we look at the questions, I talked about the self-reflection. Do we have any assumptions about how bodies need to be used in a certain way? So both I want to really highlight both the self-reflection piece. It starts with us to really deconstruct any understandings we have around bodies in general, but finding ways to be more inclusive about the types of questions that we ask to make sure that it's really expansive and open-ended around how we use bodies and how we engage in sexual activities.
Awesome. Yeah, and I will say we had Dr. Oak Reed came last year and did a webinar on trans-inclusive integrated behavioral health, and really he expands on a lot of the stuff you're saying there too. So that's another resource around that, and thank you for that wonderful answer. We are out of time. We're a minute over. We got to respect our interpreters' time and all of our participants. So thank you again so much for coming, for sharing your wisdom. It's so clear how much you have in there. I did share the slides with folks, so many good resources. So hopefully folks got something out of this. You're getting a lot of thank yous in the chat. So really, again, really appreciate you. And we're so lucky to have you teaching our students sometimes and out here working in the Bay Area. So really, yeah, look at all the love. We're just let that love come in. Don't forget, for everybody who's here, do the CE evaluations and the HRSA evaluations. Oh, wonderful. Yeah, people are loving. Beautiful.
Oh,
Thank you.
Thank you,
All
everyone.
right, y'all, have a good rest of your Friday and weekend. Thanks for coming.
Bye.